Good afternoon. I'm Dr. Campbell. I'm Rick Campbell. I'm one of the doctors here with OrthoVirginia in the East region. We have offices in Virginia Beach and Chesapeake. We have multiple offices across the rest of the state, including Richmond, Lynchburg, Blacksburg, Northern Virginia. And we are certainly happy to help you in any issues you have with your musculoskeletal care. But today we're going to talk more specifically about the role of the sports medicine physician in your athlete's care. So at the top of the screen is a term pronounced commotio cordis. This is a term that became very common and popularized after a professional football player was injured on January 3rd of this year. He was struck with a helmet in the center of his chest, and he went into ventricular fibrillation and was resuscitated on the field by the sports medicine team. That includes, of course, the trainers, the athletic trainers, but also the orthopedic and medical physicians that were there at the time attending. This is an example of something that sports medicine physicians have specific knowledge for, because it's a heart condition that's very much related to sports medicine. So for those of you who have perhaps heard about this but didn't get a chance to look into it, it is ventricular fibrillation. As you can see here, this is from an article in 2010, well before that event, which is a ventricular fibrillation, or a abnormal beating of the heart to the point that it cannot pump blood out of the heart, which then, of course, causes the sudden death. And this is triggered by a blunt, typically non-penetrating injury to the front of the chest. And it hits the heart in a certain portion of the heartbeat cycle. And when it hits it just right, it can put the heart into ventricular fibrillation. This is a condition that is something that we as sports medicine physicians learn about, because it happens specifically with sporting events, whether a direct blow with the fist or a ball, typically even baseball or hockey pucks, can strike the front of the chest and cause this event. In this article that I looked up for this presentation, this is one of the reviews that's commented on frequently, even on the websites that deal with this condition. Fortunately, this condition is very rare. It happens about 30 times in the United States a year. But when it happens, it very often is fatal. Initially, when commotio cordis was first understood, the survival rate was about 5%. Now, with it becoming more common, or at least well known and discussed, and especially after the event that was on live television in this January, there's a much more higher profile, and the treatment for this event is basically putting the patient on a defibrillator and shocking the heart into a normal rate and rhythm. So the current survival rate when this occurs is 50%, and that's completely related to the fact that there's more AED devices available at venues, and we'll get into that a little bit more, as there's a movement from the NFL to create policies across the country where all sporting venues have that device. But basically, it is one of the rare items that are the rare conditions that we as sports medicine physicians are trained to recognize and to deal with. Now, there are a number of other ones. I'm not a cardiologist, but because this is a condition that involves the heart, but also is almost specific to sporting events, is something that we're trained in or acquainted with. Other things like concussions. We, as a sports medicine physician, I'm not a neurologist or a neurosurgeon, but because many concussions occur in a sporting venue, and we are, as you'll see, part of care of the athlete in very different settings. That's something that we need to be familiar with. And in fact, concussions can sometimes are taken very seriously because there's something called a second concussion syndrome, which can also be fatal. This is also something that's very rare, has been documented perhaps 20 times, but it's something we're all well aware of. And this is what's driving the need for people to go into concussion clearance after their sporting event, whether it's at the high school level or at the professional level. And just to give you another example of the range of the training and information that sports medicine physicians have at their fingertips, we also have knowledge about teeth. So if you get teeth knocked out, which is not something that's that uncommon in the hockey world, for instance, what do you do with a tooth that's fallen out of the patient's mouth? How do you take care of that? How do you transport it? The recommendations are to put it in saline, put the tooth in saline, or put the tooth in milk and bring it with you to the dentist so that perhaps it can be reimplanted. But the point of giving you information on all those wide range of conditions is not that we're experts in any one of those, but we need to be, a sports medicine physician needs to be acquainted with each of those conditions in different fields because those things can happen in a sporting setting. So how do you get to that level? Where does this knowledge come from? And it's a long time coming. So this slide basically shows how you, at least as in terms of a sports medicine physician, how you can do that. And I will just put in a shout out to the other sports medicine type physicians that are out there and practitioners. There are very many different types of careers that are involved around sports medicine and care of sports medicine athlete injuries. And that includes everything from trainers who are extremely well trained, including getting doctorates these days, who are basically your frontline people, to sports medicine physicians who are non-operative physicians and deal more with the medical side of things, heart conditions that may preclude athletic participation and so forth. We have neurologists and neuropsychologists to help us with concussions and clear people from concussions. And then, of course, you have physicians, and there is a subspecialty of orthopedic surgery that deals specifically with sports medicine. So it starts off in college, of course. You have to be a high achiever in high school to get into a competitive college, because the competitive college helps you get into medical school. So that's sort of the goal, at least in terms of the sports medicine physician part of it. Like I said, there's different ways to do it. There are sports medicine experts in the chiropractic world as well as the athletic training world, and they come from all walks of life. But in terms of what we do, this is how you get there. So you go through 4 years of college or university, and typically you need to have demonstrated success with mastering the challenging content that there is with biology and chemistry, organic chemistry, physics, biochemistry, and so forth, so that you can present to the medical schools that you're applying to that your success in those classes to show that you can handle a complex learning. Many times now, the students that are applying for medical school will take a gap year. That's not required, but because the challenges of getting to medical school are so great, it will often take some people an extra year or two to get all the requirements, and that includes. And that gap year can consist of a number of different things. It could be a graduate school year. For instance, you can take a class, a year of fifth year of education, getting a master's in the medical world, which is many times serves as a prelude for going into medical school. And you can demonstrate your success with complex learning that way. You can take the year and do research, which is always welcomed at the medical school and post-medical school level. We have people here on site and across the state are pre-med students that have graduated and they're waiting to apply to medical school, and they become scribes where they can learn the terminology and see physicians interacting with patients in the office and get an idea of how the medical world functions. And and become familiar with the terminology. EMT is not an unusual thing that the pre-meds will do. Sometimes there's strict volunteering. I know there's people that travel abroad and work in clinics in underserved areas of this country as well as other countries to demonstrate their interest in helping all patients from all walks of life. And then a big part of that extra year is studying for the MCAT. The MCAT is a one-day test that puts together all the knowledge that is deemed relevant for medical school into one 7.5-hour test. And it's a grueling long test that a lot of times is critical for demonstrating to medical schools that you know what you're doing and that you're a worthy candidate. So then you get into medical school and you go through 4 years of medical school doing the different classes, gross anatomy, pharmacology, etc. And if you have the idea of being a sports medicine physician, then one way to get there, it's not the only way, but one way to get there and be able to give the whole gamut of treatments for these patients, these athletic patients, is you apply for orthopedic surgery residency. That gives you the ability and the training to operate on patients. You can take care of them, obviously, without doing surgery, but it also gives you the training and skill necessary to take care of patients that require surgery so that you can help fix a ligament, for instance, the ACL tear that we've all heard about but the orthopedic surgery residencies are quite competitive, and so you have to do high achievement in medical school in order to spend the next 5 to 6 years after medical school training to be an orthopedic surgeon. Now, during that time, you'll be taking care of patients and working side by side with your attendings to learn how to do surgeries, but you'll also be doing research and volunteering in the community and that sort of thing. And after orthopedic surgery residency, you can go on to hang out your shingle or join a group and work in the sports medicine world. But some doctors who are quite interested in and want to gain additional expertise, perhaps they would like to take care of a professional team. They will often do another year of training after residency and doing a fellowship. And some people do more than one fellowship. They do sports medicine, they'll do a pediatric fellowship, they'll do a shoulder fellowship. It depends on where your interest lies. But during that year of fellowship, you'll help to cover professional sports teams, typically, or Division I college teams. It depends on the setting of the fellowship and what you're looking to get out of it. There typically is a research requirement, so you write papers with the attendings at the fellowship institution and continue on your fellowship interests or develop new ones depending on where you are doing that extra training. And you continue to perfect your surgical skills, particularly for things that are more cutting edge or more unusual. We're working on injuries that have been maybe fixed in the community, but the athlete has been re-injured or has not gotten the desired outcome from the surgery. And so in these more tertiary care areas where you do fellowships, you have an opportunity to see how people can be, their careers can hopefully be salvaged again. And some people do more than that 1 year. So after you've finished all that, about 15 years, then you're ready to go into the community and start to help athletes as well as other patients. So once you're in the practice world, say you join a practice or you become an independent practitioner, which is a little bit more unusual these days. Typically, you're joining a group like OrthoVirginia, for instance. So we have different offices, different locations. So we're always in need of somebody that's a sports medicine physician. The next slide basically just shows that in order to maintain your skills and continue your gaining knowledge, because knowledge doesn't stay still, there's continued evolution of what we know to be true. For instance, when I did my fellowship in Los Angeles at the Curl and Job Clinic, I do almost none of the surgeries I learned there the same way. So that continues to evolve. You have to go to meetings, you do courses, you teach courses, you do research to help progress the knowledge. After your first 2 years in practice, once you get out of your training, you have to do what's called taking your boards. And that involves, typically it's an oral interview with a panel of physicians that are typically in your specialty. For instance, if you do sports medicine, then you would do then you meet with sports medicine physicians. They would question you about what you've been doing for the last 2 years and review your case logs to see how you've been treating your patients and if you've been doing things to what seems to be the standard of care. And if you had some complications or issues, some complex things, then you want to be able to show them that you've handled it the right way and done what you need to do. So once you pass your boards, then in the sports medicine world, you can do another level of certification. The boards allow you to maintain your ability to become a practicing orthopedic surgeon. The sports medicine world is one of 2 subspecialties in orthopedics that allows you to take another test for a certificate. This is a certificate of added qualification for sports medicine. And so you will take another test on top of the board test to demonstrate your expertise in sports medicine. And once that's passed, then you advertise or tell the world that you are now an expert in sports medicine. And that is renewed every 10 years. So every 10 years, you've got to, again, present case logs. You've got to demonstrate continued learning, which includes 240 hours of continuous medical education that is done over 10 years. And there's a requirement that you have to do some early and some late in that 10-year period. And then there's a testing period that makes you demonstrate that you know the material in a test environment, whether that's a all-day test or a longitudinal test where you can take several questions over 5 years in a row. But you still have to demonstrate your knowledge in a test setting. So you're never completely done as long as you're doing orthopedic surgery. You're never completely done from having to take tests and prove yourself. So on the right there, you see that this is an example of what happens at commotio cordis. This shows you how the impact strikes the chest. Typically, it's a younger person in the baseball or hockey world, and then typically the incidence of these injuries really kind of fades away after they become teenagers into the college world. Although, again, we saw somebody on national television that was beyond college, and it could still happen. So it's not the only. It does happen, and the treatment is basically still the same. So then, what's the role of the sports medicine physician? We'll start at the top here. So we just like any physician, this is one of the little sayings that we have as physicians is that you want to be successful, and you can boil it down to 3 A's. And the first A is affable, which means that you are able to get along with people. You're able to work with the trainers on the sidelines, with the principals on the sidelines, with the physical therapists to help you take care of your patients, with the front desk people to help to bring your patients in. So there are many people and careers that are centered on taking care of patients. In order to be a successful physician, and this is very true in the sports medicine world, that you have to be able to basically get along with. And so it helps to be a friendly person. It is difficult for your colleagues in these different roles to recommend you to athletes and their parents, or if you're not able to get along with them. So it's important to be able to do that, and I think that is as true now as it ever was. The second A is able. You've got to be able to do the job. You've got to be able to diagnose. You've got to be able to take care of patients that are sometimes within seconds of their injury, all the way to months after their injury. You've got to be able to diagnose them. You've got to be able to order the right tests, get the right bracing, have the right conversations, talk to their doctors, talk to other doctors you might need to consult to help take care of an unusual situation that involves not just the musculoskeletal world, but the neurologic world or the cardiac world, as we talked about. And then you have to be able to have good technique in the operating room. You've got to do your surgeries correctly to give the athlete the best chance to return back to their desired sport. And you have to be available. So the third A is availability, and that's where I think this separates the sports medicine physician from some of the other orthopedic specialties is that we are constantly in the community. We are attending high school football games. Every Friday night, you'll see myself or one of my colleagues throughout the state on the sidelines available in case someone should hurt themselves to help the trainers deal with complex problems that can sometimes happen. You have to be able to be contacted, have trainers at all levels in the area that know how to get a hold of me, and they have my phone number and they use it and I answer. You've got to be able to have access to your office so that you can get patients in a timely fashion to be able to help diagnose and treat the conditions, whether it's getting x-rays or getting proper bracing, getting the right orders and getting them taken care of. You have to have not only you be available, but you have to have the resources available to take care of these athlete patients. And so those three A's are super important and something that we have to work on every day to make sure that they are still functioning well. And so a big part of this, of the sports medicine physician, is being at the venue where the sports are going on. As I mentioned before, we do cover high school football, and that's done throughout the state, and we do quite a bit of it. And it's not something you're always anxious to do because it's Friday night, you've been not in the office or working all day in the OR, and then you have this obligation that you have to go to the sidelines and spend with a couple hours on the sidelines. But it's something we love to do. It's more about once you get there, you don't have any problem doing it. It's more about going, I have another, I'm not done for the day. I have something else to do today. And so we're there oftentimes till 9 or 10 o'clock at night on the sidelines, pitching in and helping out in a volunteer fashion. This is not something we typically, there's any personal benefit from, but we help the patients and hopefully we can help them off the field as well. We also work with the local colleges. And so I help one of the colleges in our area, Virginia Wesleyan. We also are working with Norfolk State as well. And then there's a professional level. In this area, in the Tidewater area, there's a few professional sports. We do assist with the Norfolk Admirals. Again, it's a pleasure to be able to help the high level athletes achieve their goals and keep them on the ice or whatever the field it is. And then sometimes you're asked to preside or assist with the medical care of athletes at events. For instance, my partner, Dr. O'Connell, was the first medical director for the Rock and Roll Marathon when it started over a decade ago. And he was head of that, and we assisted him in that matter. I was in charge of one of the AVP events, the professional volleyball beach events. It was a few years after that. And we work with the wrestling tournaments and softball tournaments and different events that are in the area. And that, again, it requires a time commitment. But again, that's part of the role of the sports physician. So when you see us on the sideline, we are there to help out. Hopefully you don't have to do anything, but if there is an injury, which is not uncommon, then you can feel comfortable that we have been trained as well as anybody in the world to help your son or daughter with their event or injury and help talk to the parents and talk to the coaches and talk to the trainers to get them back on the field if possible, or if it's not advisable, to tell you that they shouldn't be back on the field and to tell you why and what the next steps are to try and get them to recover. But our role as a sports medicine physician doesn't stop there. We do advocacy, as do many physicians. We're, of course, because of our dealings with sports and athletics, our research interests are in that realm as well. We research many times in the educational areas. You'll have a more dedicated research resources to that. This is something that OrthoVirginia is working on to build up our research resources so that we can answer questions that we have and contribute to the overall knowledge and that helps to take care of athletes and not just athletes, but everybody who hurts themselves in a musculoskeletal way. I mean, maybe you don't consider the mother that runs in the morning before her kids get up, or the guy that comes home from the office and goes to the gym and does yoga. But those are people that can hurt themselves in those venues, and they need help as well. And so this research not only can be applied to the weekend warrior or the part-time athlete, but also the full-time athlete, and information that is divulged or gleaned from those studies can be used to take care of all types of people that are hurting themselves in a musculoskeletal way. Our rotator cuff repairs done arthroscopically are typically not done in athletes, but they were much of the impetus for learning about how to do those was done on athletes, and so we've taken those techniques and expanded them into some of our non-athletic venues. We do community outreach. We do education, things like Facebook Live presentations. We give talks throughout the community, different hospitals, and we've all gone to physical therapy institutions and gyms and libraries and shared our knowledge with the community out there. This is part of sharing what we've learned through all these years of training to help everybody understand where we are and what's on the horizon there. And then circling back to the commotio cordis issue, this is something that we, in fact, just had a meeting in Washington, D.C. with the American Orthopedic Society for Sports Medicine, met at Washington, D.C. And as part of that meeting, there was a meeting of the Council of Delegates. It's a committee of sports medicine doctors from across the country who have been selected by their peers to represent their state in a large committee to help share ideas from different areas in a national way. And during that meeting, we heard a presentation from a representative from the NFL who has a extension and a desire to help with this kind of condition, have started what's called a Smart Heart Coalition. And the idea and one of the policies that they want to help spread is to make sure that there are AEDs or defibrillators at every sports venue, every place where commotio cordis could potentially occur, because if there's not, and that condition does occur, it is not a good prognosis. That AED device has to be basically on site for a fatality to be prevented. So you'll be likely hearing more about that. And one other issue that's come up in terms of sports medicine professionals is an issue with our ability to travel outside the state. So in various states, you may have heard that there has been with athletic patients that have had injuries and have not been able to get back to their sport. Sometimes they feel as though they've not gotten the best care, and there is a lawsuit that results in that. One of the challenges that's happened now is that, and you may have seen about a statement from our society, and ESPN has mentioned this as well, is that that's fine if there's been a problem, but when these lawsuits come up, they need to have people that testify that know the condition and know what's to be expected, so that the award is just. and I will, some of the more more publicized award that happened to a recent player was quite a large award, and unfortunately, the malpractice carriers do not have coverage for that level of award. And so our society is saying that this is perhaps something that was excessive, and with different testimony that may not have been found to be just. But with the consequences of that award are that now it's going to make it more difficult for sports medicine physicians who typically would travel with their institution or their college's football teams to go out of state, where they're not necessarily covered by their malpractice carrier. That's going to make it very difficult for those sports medicine physicians to travel with their team if they're going to put at risk for these extremely high levels of awards, because we literally cannot get malpractice coverage for that. So that's something that's a grave concern to our sports medicine profession, and something that has to be worked out so that it's fair to all parties. But because we still would like to help take care of your athlete on the field or wherever we can help you and get them back to the sport or get them back to their desired activities going forward. So that's the end of my formal presentation, and so I'm happy to take any questions that have occurred to anybody about any range of sports medicine topics.
Thank you, Dr. Campbell. We do have a few questions. So one of the questions is, when should an athlete go see their regular physician or go see a sports medicine physician? How do they make that determination?
It basically kind of depends on what their condition is. So if they have chest pain, then that may be something that you want to talk to your primary care physician with, because they'll be better suited to evaluate the different kinds of chest pain, whether it's musculoskeletal from a rib, or whether it's a lung or a heart issue. So something that's more in the central body would be something, maybe start with your primary care physician. But if it happened as related to a sports injury and you say had a blow to an area of your sternum, then that you can certainly come to a sports medicine physician directly. If it's something that it's in your extremity or neck or that kind of thing, then I think that, again, if it's related to an injury that happened all at once, a sudden onset of a problem, say you're bench pressing and all of a sudden you felt a sudden strain in a muscle in your chest, then you certainly could consider in that setting to go directly to an orthopedic surgeon or a sports medicine specialist. So it really depends on how the problem started. The more acute, the more likely that you'll find a sports medicine doctor can help you with that, versus something that has come on very slowly without any obvious event. Then you may want to reach out to your primary care physician and let them take care of it and see what they think before sending it on to one of us.
How does the sports medicine physician work with the athletic trainer at an athlete school to care for the athlete?
That a little bit depends on the venue. For instance, in a collegiate level, typically we'll meet with the trainers before athletes report. Say it's a university or college setting. So we'll meet with the trainers before the athletes arrive on campus to start their preseason workouts and training. We'll go over the rules and the changes that have happened. For instance, the NCAA regulates a lot of how the athletes can be cared for and how the practices occur. And so sometimes there'll be changes that occur over the summer while college is on hiatus. And we'll review some of those changes that have happened and how that affects what we do. We'll set up how the programs are going to be done during the year. For instance, when I'll be on campus to see athletes in the training room, we'll go over some of the events that are planned throughout. Is there NCAA tournaments potentially that we may be able to plan for those, and just kind of work out what the resources are to take care of the athlete. Once you've got that set, then we sometimes will help with physicals when the athletes arrive. Some patients have had, if they're incoming freshmen, they may have had surgery as a high school senior and they're not quite recovered. And so you'll need to kind of review that with the trainer and work out a rehabilitation program so they can finish, getting better from the surgery they had at their hometown. And then once the season starts, then we set up a regular meeting time where I would, for instance, go on campus in a regular setting so that the trainers can expect when I would be there. Now, if there's nobody that's got injured that week, then we don't necessarily do that. Or if it's more convenient or more urgent, then they'll come to the office. Typically, they'll reach out to me and text me and say, hey, we just got back Saturday night and looks like somebody hurt themselves and didn't tell me until the next morning. And so can you see them Monday morning? And then we arrange for them to come in a timely fashion so we get their treatment started. So typically that's how it goes through the year. And as tournaments come up, for instance, at Wesleyan, they're routinely doing softball tournaments. Their women's softball has been very successful. So it's not unusual that they'll have a softball tournament at the end of the school year, and we'll be able to help out with that, cover some of the tournament events that way. So that's how it kind of unfolds. But it requires basically constant communication, weekly communication, so that the trainers can get a hold of us and work with getting their athletes the care they need, and make sure that the MRIs are followed up on, and what's happened with this person, and how come they didn't come to therapy, and can we get this person back on the field? So there's a lot of work that goes between our staff and me and the trainers, and the coaches don't really get too involved. The trainers are the go-between between the care and the coaches, and that's probably how it should work. So that works pretty well.
Is there a specific age range that sports medicine physicians treat?
We treat basically from any time when the range of athletes would be as young as when organized sports start. I mean, fortunately, the 3-year-olds that are playing soccer, when they're running around in big clusters on the field, they are pretty resilient and rarely have any injuries that require our attention because they aren't moving very fast and they're not very big, so the inertia doesn't create a lot of injury. But as people get bigger and faster, then we start seeing more and more of those kids as they go into their adolescent years and certainly in the high school years and college. So it can start as young as grade school, but that's not as common as it is for the guys and gals that are in the high school years. So and then of course after that it just goes all the way to 90-year-olds playing pickleball. So we see a full range.
Thank you so much. That is all the time we have today for questions. Dr. Campbell, would you like to close?
Yes, I just wanted to say thank you for the opportunity to share a little bit of behind the scenes where we come from, and you may see us, and hopefully don't see us very much on the sidelines of your local high school or college or a professional activity. You'll see there's always going to be someone at these venues helping out, and so now you know why we're there, and hopefully we don't get too busy, but if we are busy, we will do our best to share information with you in a timely fashion so that we can help your athlete get the proper care they need and get back on the field or back to their desired activities as soon as possible. So if you do have any issues that come up, then please contact us at orthovirginia.com. And almost anywhere in the state of Virginia, you'll find an office that has sports medicine trained physicians that can help you with your athlete.